Hi, thank you so much, and hi everyone who joined us today. We are glad to have you at our session today. I am Sandile Mahlangu from Eswatini Hospice at home. With me, I'm having the team that we have here at Eswatini Hospice at home. We hope others will join and find us along the way. By this time, I give everyone an opportunity to introduce self. I will start with my team this side so they introduce themselves.
Hi everyone, my name is Samanele Nkambule. I'm a palliative care nurse under Lubombo region, working for Eswatini Hospice at home. It's a pleasure to be part of today's session. Thank you.
Thank you. May we have Sibongile introduce self?
Hi everyone, my name is Hospice Melani, hospice nurse at Hospice at home. I'm glad we are going to have a good session today. I'm sure everyone will enjoy. Thank you.
Thank you. May I have Bogima Musa introduce self?
Hi everyone, my name is Bogima Musa. I'm a nurse at Hospice at home.
Thank you. May we have Nancy Kelly introduce yourself?
Hello everyone, I'm Nonsigelelo Ntuli from RFM Eswatini. I'm a nurse at Palliative Care Unit. Thank you.
Thank you. May we have Stembile?
Good afternoon, everyone. My name is Stembile Shiba, and I'm just listening in. I'm from Royal Eswatini Sugar Association.
Thank you, Stembile, for joining. May we have Petile? Petile.
Hello. Morning, everyone. My name is Petile Shiba. I'm from Diabetes Eswatini.
Thank you so much, Ms. Petile. May we have Simo?
Hi everyone, I hope you are well. I am Simo, I'm a nurse, and I'm looking forward to benefit from today's session. Thank you.
Thank you. Thank you. Thank you, everyone. Also, we have Romina.
Hello, everyone. My name is Romina Joseph. I work as a senior executive with the replication team here at ECHO India. And good to see you all. Happy learning session to all of you.
Thank you, Romina. William, you want to introduce yourself?
Hi, good evening, everyone. This is William, and I'm also working at ECHO in the replication department. And it has been only 7 to 8 months that I've been associated with ECHO India, and I'm very happy to be part of your program and wish you all the best. I'm so sorry because my web camera doesn't work, so I'm not able to open my camera. Thank you so much.
Thank you. Thank you, everyone. I hope I've not left anyone. We are hoping to have others. Oh, I have Zoda. May you introduce yourself?
Thank you, Sandy, and thank you everybody who's come. I'm Zota Kamete, working for the Hospice at home. Thank you.
Thank you. For the second time, I will continue with the session. I'm hoping to receive others who will join us along the way. Overview of the session. Last session, we were looking at advanced care planning and the goals of care. We discussed on the importance of advanced care planning, and we also looked at the process of discussing advanced care planning, which involves the goals of care setting, which is the goal of therapy, and then we look at developing the directives in terms of who, what, and where, and when the care should be provided, and we also look at making a decision about the specific forms of treatment or therapy. We were looking about those things. We also had a case from Manzini Hospital, which was a case of the 40-year-old married female with cervical cancer advanced stage, who was presenting end of life and different social issues that were presented. We looked at the patient was diagnosed in 2019 with stage 1B, but then now he has developed advanced fistula, DVT, and and the patient was initiated to the chemo, but later, due to the fact that it's not going to be feasible, it was then withdrawn. We also understood that there were issues that the patient had, which included family issues, that the patient didn't want to see her families. We also noticed that the family had unhealthy family dynamic that contributed sometimes to the care of the patient. And we also identified that the patient has spiritual issues, especially the husband, who don't believe that the cervical cancer may be medically related. He said that is a traditional issue. So if the wife is not cooperating, it's not available to support until he wants to take him to a traditional healer. We also found that there are also issues of goals of care in terms of discussion with the husband. We also look at the issue of caregiving burnout, especially with the child. And then we also discovered that there were also ethical issues that the facilitators to deal with, which included the issue of the patient refusing to take morphine, and also the issues of withdrawal of active chemo. And then we also look at the issues of finding a way of scheduling a meeting. Unfortunately, for now, I don't see those people from the hospital, but that was we discussed last week, and we look around those issues. Today, we are going to have a presentation and overview of ECHO, of what it's all about and what is important in the society. We are taking a break from the series. This month, we were treating the series, or we are treating the series on communication in palliative care. So we say that we will take a break today and look at the project or the program itself, which is ECHO, and then we'll look around on how we can then grow on it. And then next session, we will continue with the other goals of care, and then we'll see how we are going to continue that trend. For this time, may I give this opportunity for Romina to present on the ECHO for us.
Thank you so much, Sandile, and let me just share my screen. I hope my screen is visible. Yes, so like I mentioned in the beginning, my name is Romina Joseph. I work as a senior executive with the replication team here at ECHO India. And I've been working here for the past 2 years. So I would like to take this opportunity to walk you through what ECHO is about, how do we go about our partnership, and what's the kind of support that we do. So just a bit of background. So the whole idea of setting up ECHO, or what led to the incarnation of ECHO, was across the globe, 6 billion people all over the world are suffering and dying just because we don't, they lack the access to the right medical knowledge at the right time. And that is what kind of led to the idea of bringing in Project ECHO, which is a simple, scalable, and highly effective method. And it tries to address this crisis by democratizing knowledge. That is, bringing in knowledge at a local level instead of restricting it to certain institutions. and thereby rapidly increasing the capacity to provide expert best practice care to underserved population. Now, ECHO has been, over the years, it is developed and spread across the globe. And now currently we have a global network of over 400 leading health and healthcare organizations. And the same has been implied or implemented to kind of build capacity when it came to COVID-19 management and has and other 70 other chronic diseases. So as of today, the goal of Project ECHO is to save 1 billion lives by 2025. So just to talking about, just give me a second. Yeah. So talking about COVID-19 work, we all know the kind of burden that COVID-19 imposed on the existing healthcare system. And however, by rapidly developing the competency, ECHO has been able to support over 180 members from its existing network to train over 600,000 healthcare professionals across 15 countries. So these would include nurses, first responders, ICU and critical care specialists, testing and laboratory personnel, and the list goes on. And over the course of these 1.5 years, the emphasis has now been shifted to focusing more on the global south and setting up projects in Africa, Asia, as well as Latin America. So this basically, as you can see, is a map projecting the hubs that we have across the globe. And as of now, we have about 602 global hubs set up. Among these, it's spread out, as you can see, it's spread out across the globe. But predominantly, we have over 250,000 hubs set up exclusively in and around the States itself. And gradually, we are trying to bring in more hubs in Asia, like I mentioned, Asia, Latin America, and similar lines. So this map, similar to the previous one was focusing more on hubs, and this one focuses on the global super hubs that we have set up. So existing, we have about 28 super hubs already in place, and we have another 5 new super hubs joining in the line. Now, this map would kind of pictorially depict how the placement of the existing and new super hubs happen. The difference, now you might think, what is basically the difference between a hub and a super hub, or why do they have 2 different maps in the first place? So the difference lies predominantly in the fact that the latter, which in this case is global super hubs, have the credibility to train hubs to start new ECHO. So among the different partners that we've been working with, one such university based out of Zambia had the opportunity of launching another 5 new ECHOs under them. And thus they have led to the process of transitioning into a super hub. So basically, once you have run into developing your own ECHOs is when you get promoted from a hub to a super hub. And ECHO India is one such super hub. Now, to talk briefly about the ECHO model, as mentioned in the first slide, ECHO does not directly treat patients, but instead focuses on capacity building by training local healthcare providers. So there are about 4 principles, which, as you can see on the slide, focuses on how we kind of bring together this whole transition of knowledge and how we try to focus more on moving knowledge and not people. So to begin with, the first one is technology. The tools that we provide enables a virtual learning session, which brings together a group of experts and other participants to join these sessions to learn from them. The participants from these sessions get to learn from these and thereby impart the same locally, thus ensuring better treatment at local level. So what happens is similar to what we have right now in this session. We have a couple of palliative care nurses joining us. So what we learn here, or a case discussion that happens here, so we all have been connected through technology, and it has enabled us to join from different parts of the world. And yet what we learn from here is then imparted or spread on to our local centers or wherever we are working with. So that thereby transfer of knowledge has been happening. The second key principle is sharing of best practices to improve quality care and reduce treatment disparities. So everything at ECHO is evidence-based. We've always encouraged our partners to share guidelines or practices that are backed by evidence, thereby ensuring that there is no fall short in terms of what we are imparting through these sessions. So thereby ensuring a more evidence-based learning and sharing of best practices so that we all learn as a community. The third principle would be master complexity through iterative guided practices, co-management of patient cases, and collaborative problem solving. So this is kind of one of the crucial and key principles of ECHO. This makes it to an essential principle in that participants, while discussing or presenting their cases, learn in the process by discussing their issues and gaining advice. So it's not just a one-way transfer of knowledge. How we see it as, or what we try to impart through our partners, is a two-way learning street wherein it's not just the providers or healthcare providers in this case imparting their knowledge of best practice, but also the participants, by bringing in their case, by bringing in a discussion, they also try to learn and in turn teach the providers as to how things work at a local level. And finally, measure, report, and publish outcomes. So we focus from ECHO side, we try to make sure it's not just setting up a good program, but also being able to empirically show how these programs have brought in the desired outcome. And how we do that. So we have a team exclusively which kind of works and assists with all the data requirements. So we'll be happy to kind of support in case you want to develop how there's been a outreach from any particular program that you desire to run. And in this case, focusing more on palliative care. So to sum up, ECHO is a highly collaborative all teach all learn system. Like I mentioned, and I think that's been reiterated through previous slides as well. So it's not just a one-way direction of transfer of knowledge, but two ways. And in that process, moving knowledge and not people. So it is not meant to be just a presentation of a lecture, but more of a discussion, an interactive session wherein there's question answers, there's discussion, there's sharing of best practices, and sometimes also leading experts to learn about the practices in rural areas in terms of local context as well. So whether patients or providers, the idea is to move knowledge, like I mentioned. And also on that note, another aspect that we try to cover is bringing a multidisciplinary team who bring in their own expertise and thereby provide a holistic approach of treatment. Now, in case of palliative care, I myself had the opportunity of working with another organization, and that's something that I observed there as well. So it's not just the medical professional, it's not just the doctor, it's not just the nurse, but when it comes to palliative care, it's always good to have a holistic approach wherein there's a psychologist involved, there's a pain management expert involved, there's a social worker involved. So that's the kind of learning platform that we're trying to bring in, wherein there's not just one stream of knowledge with multiple resources coming in together for providing the best care for that one particular patient or the case being presented. Moving on. So that was an overview, but let me walk you back through what led to the initiation of ECHO, or how did it come into existence in the first place. So this picture is a screenshot of the first ever tele-ECHO program that was held in New Mexico in the year 2003, and the session was focused mainly on hepatitis C. So Dr. Arora has been and still is one of the most renowned experts when it comes to hepatitis C. And for the very same reason, when patients used to reach out to him, there used to be a waiting period of 8 months because the number of resources were less, but the amount of patients affected with the same was more. And that is what kind of led him to bring in or bring in a sort of platform wherein there's knowledge sharing happening to the local level, so that the patients don't have to wait all the way to meet him at his particular organization, but rather the same or the very best care is being provided at the local level as well. So as you can see in the screenshot, there's the major box is where ECHO Way is from where Dr. Arora led the session. And it's not just, as you can see, it's not just Dr. Arora sitting there, but a multidisciplinary team altogether. There's a whole lot of different professionals coming in to provide the best possible solution or best possible practices to kind of work towards the betterment of hepatitis C. And the remaining smaller boxes are the ones, those different sites from where the professionals join to discuss the cases, to kind of get a sense of what better can be done at their level to make sure better treatment is being provided. So moving on. Now, what happened is, so this was back in 2003 when the first ECHO happened. And further in 2011, a study was conducted on this pilot program and the results was published in a journal as well. As you can see from the pointers itself, there were about 407 patients which were a part of the study. And a comparison was done about the treatment being provided to these patients at the university where Dr. Arora was, as compared to the different 21 sites, which included prison sites as well. And to much of our surprise, or something that we were looking forward to, the results were astonishing, and there was no difference in the cure rates between these two groups. And also there was no difference in the serious adverse events as well. While at the same time, the patients were glad to receive the treatment closer to their homes. So they didn't have to travel, they didn't have to go through the waiting period. And even the doctors felt safer or better enabled to kind of treat these patients independently. So this study, which focused on managing the patients at the university versus these 21 sites, kind of it just reiterated the idea how a platform like this could bring in resources and provide better care to all the patients across the globe. So that is how the whole initiation of ECHO happened. And what started as a healthcare-oriented platform has now grown to much diverse domains as well. So what you see in green are certain other related aspects to healthcare that we already have programs running in. And also, it's not just, we've grown even more than just healthcare and healthcare-related projects to other projects such as business, social welfare, livelihood, law enforcement, education, etc. Now, moving on to replication initiatives, specifically in Africa. So this is one such, or this is the team that predominantly me, and in this case, William is also working with. So we kind of work with different organizations based out of Africa. I will be going more into details. So based on the work that is being carried out in Africa, it is projected that by the end of 2022, ECHO aims to establish 150 different partners running different programs across Africa. So this lists out the existing ones, the existing partners that we have and where they are based out of. So as you can see, there are, so in case of like Kenya and Uganda, we already have about 20 to 35 ECHO hubs in place. And somewhere like Cameroon has already 4 existing hubs. So it's not just 1 or 2 countries that we're focusing at, but all across in all the 50 countries, we're trying to bring in as many hubs as possible. And in this case, the forecast is 150, out of which 140 is already there in place as of today. Now, this is the dashboard that we prepared, trying to emphasize the reach. So like I mentioned previously, we do emphasize empirically backing up the reach that we bring in through these programs. So we kind of push the same idea to our partners as well. So this is the briefly put how ECHO India, along with Project ECHO, has supported or the global reach that we've been able to come across through the past 2 years. And it's a little bit outdated. So what is seen as 54 hubs, as of now, we have 58 different projects across the world, out of which many are in Africa. So to go a little bit more in detail, as of 20th of June, we some of the partners that we are working with and where they are located is what is listed out in this slide. Particularly, in certain cases, we've had a larger partnership in place, like with organizations like Assistance International. We have about 10 projects already, and partners like Infection Prevention Network or ICANN, for that matter, have already 7 hubs in place or 7 projects in place across different countries. So currently we're supporting 49 projects in Africa across 19 plus countries. In addition to this, so this is solely backed by, this is solely being supported by ECHO India. We have other partners as well based out of Africa, which is supported by ECHO Institute and other super hubs across Africa itself. Yeah.
Oh, okay.
Was that a question for me? Okay, so moving on. So now talking about the partners in the same line, ECHO has had the opportunity and still we're working extensively with MOH across Africa. The ones on the slide are where we have a formal MOU signed, that's a memorandum of understanding. We do have many more government agencies and government associated organizations where we are working on a more informal basis, but the ones, like I mentioned on the slides, are where we have a MOH signed as well. So we do have a wide range of partners on board. And one such organization, which I think all of us are aware, in case is WHO. So we do work with both WHO Afro and WHO headquarters as well, in and around topics pertaining to COVID-19, and there's much more. So what this shows is yet another dashboard that we prepared for a program that was run predominantly by the World Health Organization and focused on national deployment and vaccination planning and implementation. We had about 845 participants joining us from 390 cities and 542 different organizations. So that just explains the kind of reach that we bring in through this platform, and how much it's just from one location, the knowledge is being imparted to many such organizations and different cities. And this is a publication that WHO had made from their end with this journal, Human Resources for Health, and they had explicitly explained the outcome of the project and how that brought about a difference in terms of capacity building. Now, coming back to Project ECHO support, what do we, or how do we go about our support? What's the kind of support that you can expect? So most of it, I'm sure you must be already aware, because now that your organization is already launched with us and it's been running sessions successfully since January, you know how the kind of support that you can expect from us. But nevertheless, I would still want to go through it for any future prospects that just to get a sense of what do we mean by when we say the support that we'll be providing. So talking about the support, I'm sure as you can see on the screen, there's majorly 5 categories of support that we provide. To begin with, non-cost technical assistance. So since it's a predominantly technology or tech-oriented platform that we're using, we do support the partner with setting up and session planning, and also like a dedicated relationship manager design. There's a IT support that's in place. So depending on the scalability of the program, the reach or the amount of audience that's involved, we do bring in more resources to make sure the sessions are running smoothly. In terms of no-cost ECHO training, monthly ECHO immersion trainings are held for new hubs, training for participants, and hands-on training for ECHO-Spark. ECHO-Spark is a software that we use internally for data management. And so we are always happy to support and provide the partners with training as and when they feel there is a need for the same. A no-cost software and database support. So like I mentioned, ECHO-Spark, and now we have ECHO as well on board. That's something that we provide from our end for data management, and we do provide training on the same as well. And there's also Zoom license that we issue to partners once they reach a couple of sessions to build an independent network of knowledge. It's not just we have to constantly be there. I mean, we give you the space to make use of it to the best of knowledge sharing possible. And no cost access to Pearl, which is Project ECHO Resource Library. So that is like a repository of the curriculum, different didactic presentations and references that are used not just by a certain bunch of partners, but all the partners that we have on board. They do have access to this Project ECHO Resource Library, which in other words we call it as Pearl. So that way, it's not just we learn, or there's a knowledge sharing within the circle that you have in place, but rather you get to kind of bank on the knowledge from other partners as well, what they do in their sessions, what's the kind of case studies that's been brought in, the didactics. So there's sharing of knowledge across the network as well. And finally, no cost monitoring, quality assurance, and data analytics support. So like I initially mentioned, there's session planning. So we do provide them with project planning, conceptualization, post-launch feedback. The dashboards that you saw in a couple of my previous slides are all what we develop based on the partner requirements. So that is something that you can always use back for reporting purposes or just to have a sense of the reach that's being. So that is just one aspect of the support that we provide. There's much more to it. There's pre and post evaluation that we can come up with. So depending on the partner's requirement, we do come up with much of the resources and what best that we can support the partner. And finally, there's so having spoken about how ECHO came into existence, having spoken about the kind of support that we provide, what makes ECHO work, or why should we even go for ECHO? That's one question that I think all of us do think about. Going back to the pilot study that Dr. Arora had done based on the pilot program that was brought into place, and having looked at how in terms of treatment, the outcome was just the same, whether it was meeting the direct doctor itself or just having it treated at a local healthcare center. So how does that happen, or what is it that makes it work the way it does? So it's again, it can be focused on majorly 4 principles. That's technology, post multiplication, democratizing knowledge, and all teach, all learn. So going back to what was initially mentioned in one of the slides as the 4 key principles, to begin with, because it's predominantly technology based, so it enables for a team-based care. So you get to leverage on sparse resources. So what we have in one particular organization, the other participants get to bank on the knowledge that's being provided by them. There's force multiplication. So task shifting and community of practice by way of social network allows for force multiplication. So like I mentioned previously, it's not just the provider imparting knowledge to the participants, but it's a two-way street where the participants also kind of bring to the table what they have based on their experience from a local level. Democratizing knowledge, so that kind of sums up, or that predominantly explains why there's so much of a thing about ECHO, or why the whole idea of ECHO is to not just limit the knowledge to certain individuals, not just limit the sources to certain professionals, but rather imparting that knowledge, creating a learning circle, creating a global network wherein there's always room for healthcare professionals to reach out and get hold of better resources. So that happens through interprofessional consultation and merely the joy of working together. And finally, coming to the most important factor, all teach, all learn, ECHO thrives on guided practice. Like I mentioned before, there's a lot of evidence-based learning. There's a lot of multidisciplinary approach that we try to reiterate and bring into our partners. So by all teach, all learn, we're trying to build a mentor-mentee relationship, or rather a movement of like it's a movement that's brought in to build knowledge by bringing in people from across the globe, rather than shifting those institutions, rather than shifting those particular resource persons to different locations. So with that, I am done with my presentations, and I'll be happy to take up questions if any.
Thank you, Romina, for such a wonderful case. From the presentation, we can take and read that ECHO is for sharing correct practices. It's for case management. It helps us do that. It also helps us to build capacity to provide knowledge and expert care. And it supports and promotes multidisciplinary teams. So all of us we come with different knowledge and experts in the care of the different cases. It's for the movement of knowledge instead of people. In our setting, natural setting, we are used to move into certain areas for training to get knowledge, but through this platform, we are promoting that we move the knowledge in our respective areas while we are still at work. So we promote the movement of knowledge only other than people. And also it involves the collaborative learning and teaching all together. We all learn and we are all teaching one another. So it involves the issue of care at no cost. So we reduce the payment of knowledge, but we work as a team together. So that's why we are also embarking on ECHO, So you are adopting such a model even for palliative care for our country, that we move together in the care of our patients with terminal and life-threatening illnesses. Thank you so much, Romina. I don't know anyone with a question for Romina concerning ECHO or a suggestion. You may raise your hand or you can write on chat box. If anyone has a question to ask Romina, or a suggestion or a comment, you are free to share it with the team. You can also share it on chat box. In the absence of an patient now, maybe as we are continuing, we hope everyone has understood and adopted such a great model. And we hope it will build our country and it will help us meet even those people who are hard to reach in terms of care. We are going to be able to provide the quality care that we wish we could provide to our clients without exhausting a lot of resources, but moving the knowledge and the skills that we think can help us to go forward. So last time, there is a question for you, Romina, from Stembile that says, which communities are you considering to start with in Eswatini?
Thank you for your question.
Yes.
Sorry. Yes. So to answer that question, I might be pronouncing the name wrong, but in terms of community, it's not for us to. I think we leave it on the partner organizations that we're banking on, like in this case, ECHO-Eswatini Hospice at home. So what we're trying to bring in is whatever community, whatever places that they are working with, and what best can be done to impart that knowledge. So it's not what we try to bring in is bring in partner organizations on board and enable knowledge sharing as much as possible, and thereby imparting knowledge. So we have a wide range of topics that I have covered in my slide as well. So we'd be happy to take as many communities, or there's no specification from our end. All we are trying to do is bring in resources together so that there's appropriate sharing of knowledge and better treatment being available. I hope that answers your question.
I hope it is answered, Stembile. Thank you. Yes, so that's why we are also having palliative care ECHO here at Eswatini, so that we can reach the healthcare professionals, so they can be able to transfer the same knowledge in the care of the patient in the country who are in need of palliative care. So we are looking forward to every healthcare worker in the country, regardless of the profession or job description, as long as you are involved in the care, so that we ensure that all people or all patients that we have, especially in the country, that are in need of palliative care are reached, and they get the same, whether you are in Lavumisa or you are in Mbabane, so you can have access to the same service like everyone, as long as we are moving the knowledge. So that's why we have this platform through the support of the Indian team. For this time, you are free to continue, put your questions on chat. If you have anything to say or any question, may I give this opportunity to RFM Hospital Palliative Care Unit to present the case for today. Nonsigelelo. Please, share screen, please.
Hello.
Go ahead, no, that's again, no.
Hello, everyone.
I'm Nonsigalelo Ntuli from RFM Palliative Care Unit. We'll be presenting our case, a follow-up patient, 47 years old male, diagnosis, Kaposi sarcoma, nodular stage. The problem with the patient is that his clinical condition is deteriorating. Lesions have extended from left foot up to the left arm. Concern, patient have not yet started chemotherapy. She complained of pain on left foot, chest pains, and oozing of the lesions on left foot. Chief complaint, patient is complaining of moderate pain on left foot with lesions that have extended from left foot up to the arm. Patient did biopsy end of March 2022. He came to check biopsy results. Significant medical surgical history. Patient was enrolled on palliative care 28 February 2022. He presented with growth on the left side of the waist and moderate pain. She was previously diagnosed with Kaposi sarcoma and received chemotherapy at Mbabane Government 2021. Patient on ART since 2 years ago. On examination, visible black lesions on left side of the waist was seen and it was oozing. Edema on the left arm and leg noted. 31 March 2022, a biopsy specimen was taken for histology in Mbabane. He came for dressing of the wound until it was completely healed. 12 July 2022, he came to check his biopsy results and also complaining of chest pains, moderate pain on left arm and leg with edema, black, oozing yellow, foul-smelling liquid. Biopsy results collected at RFM laboratory, and it has confirmed that patient has Kaposi sarcoma, nodular stage. Current medication, tramadol 50 milligrams PO 3 times a day, Bisacodyl 10 milligrams PO, Noctare. Social history and pertinent family history, work status, partly compensatory, occupation is self-employed, education, completed high school, socio-economic class, middle class, marital status, marriage, lifestyle habits, occasionally take alcohol, relevant health condition in the close family members, mother on diabetes, and one of his sisters. Advanced care directives, they were not done. His next of kin is his sister. We cannot say much about the advanced care directives and healthcare proxy. Review of systems, vital signs, temperature 36.8 degrees, BP 121 over 65 millimeters of mercury, pulse 79 beats per minute, respirations 20 breaths per minute, oxygen saturation is 96%, pain score is 6 over 10, ECHO functionality score is 2. Symptoms, pain, it's moderate, dyspnea 0, it's none, there is no dyspnea. Anxiety is severe, agitation, it's severe, drowsiness and fatigue, it's severe, nausea and vomiting, there is no nausea and vomiting, anorexia, it's moderate, constipation, it's mild, dry mouth, there is no dry mouth, mobility, it's moderate. focused investigation, it was not done. Special investigation, they did biopsy and the specimen went for histology and confirmed that the patient has Kaposi's sarcoma. Further plan, client was seen by the doctor. After we received the results from the laboratory, who wrote a referral for the patient to start chemotherapy at Moneni Oncology Unit. A refill of tramadol and bisacodyl was made for the patient. Advanced care directives not yet done. Further assessment and management will be done next visit. Thank you.
Okay, thank you so much. What I can say, I've got that the case is a married 47-year-old male with a Kaposi's sarcoma nodular stage, diagnosed on March 2022. The patient is on deteriorating phase of palliative care with moderate and severe pain, with a smelly watery discharge that is yellow. The patient I've got that has been initiated into palliative or referred to palliative care on the February this year. I understand that the patient was once on chemo last year, and the patient is on ART. The patient that we have is depression and anxiety. Has some social information that the patient is married with a sibling and has a mother who's also on diabetes mellitus and is taking treatment. The patient was referred to Manzini Hospital for chemo. Not yet involved or initiated on advanced care planning, and the patient was scheduled for assessment on the next visit. May I give the opportunity for the team to share a comment or any question? Anyone with a question or a comment for Julie? Anyone with a question for Julie or a comment concerning the patient? Is asking Julie if or what is being done with regards to his diet. Hello, Betsy. Well, Ziggy.
Hello.
For you, Ziggy. There is a question for you from Betsy.
Hello.
Yes, may you answer Betsy's question?
Okay. Usually we do health educations. There is nothing we can provide for them to compensate the patients.
Okay. Do you get the response, Betsy?
What to eat so that they can have energy.
Betsy? Are you answered, Betsy?
Hello.
Did you get the response?
I just said nothing. I don't understand nothing. like are they not supposed to get the treatment advice and then the diet?
I think I'll get you that they need to get treatment advice and diet also. Anyone with another question? Okay. I see another comment there from Ms. G that say I might have missed this since he was on chemo before. What might have contributed to the state of his condition, such as how is the viral load? There's another one that says from my comment that says might miss this since he was on chemo before. What might have contributed to the state of his condition, such as how is the viral load? Hello, Ziggy.
Hello.
Yes. Welcome to this question.
Okay, I didn't hear the question well. Can I have a repeat on it?
Okay. The question is, the patient was on chemo before. What might have contributed to the state of his condition now? As how is the viral load?
Oh, okay. The hello.
Yes, Ziggy.
Oh, okay. Another problem with this client is that he is not telling us all about his health information. And we've been calling the patient to come for biopsy, but we couldn't find her through the phone. And so the lesion will extend from the leg to up the body, up to the left arm. And we didn't see his green booklet to see whether he is taking the medication appropriately. I think that's maybe we can say it's our weakness on managing the client. I may say that. Because he is that client who can't be open to us and tell us all about his health information.
Thank you, Ntigelela. I hope Marika Menza has got your response.
Thank you, Mahlangu. I did. I only hope we will refer this client to social workers for follow-up and further linkages and assistance. Thank you.
Thank you. Anyone else with a question or a suggestion or a comment for Notigelo and for RFM Hospital Palliative Care Unit concerning the patient? On that note, may we kindly request that we introduce our name and place where we are connecting from. On chat box, you write your name. I'm Sandra Magiamu from Eswatini Hospice at Home and nurse. So that's how you can write it on chat box. Write your like register your name, my name, and then your profession then or your position, and then your place of work. We can appreciate that too. Petsile is saying, I feel more should be done for the patient. I agree with Petsile. There's a lot that needs to be done on this patient. I get not getting that there's still more that needs to be done. So anyone else with a question? Mabuza Bomi has a question next to me here.
Evening, colleagues. I just have a small question concerning the chemo. Well, is the patient aware about the chemo? Is it a therapy chemo or a palliative chemo that the patient is awaiting to receive? If there's any information about that, I think maybe the patient has a right to know if the chemo is awaiting is for palliative or it's a therapy. Yeah, it's a curative chemo or a palliative chemo.
Thank you, Mabuza. I hope you have get Mabuza's question, Ziggy.
Well, the chemo is a curative chemo for Kaposi's sarcoma.
Is the patient aware?
Okay. I can see my comment is raising a hand. You can unmute and share your comment, madam.
Okay, thank you, everyone. From what Ntsigi has said about the condition of this patient, I'm not sure, I might not be well informed, but for chemo, I think this time is going to be for palliation more than curative, especially if this patient is not virally suppressed, because the condition from what she's saying is quite on the bedside. But again, I will say it could be for curative if more assistance, like Petile said here, is afforded to this patient and he's helped out of this current condition. Thank you.
Thank you, Marika. Thank you. May we keep on registering on the chat. Thank you, Petile, for initiating the process. Anyone with a question and a comment to support or assist RFM Hospital to manage this patient better? Okay. I can share a few things. Thank you so much for the comments that you have shared. There's a link that you have provided in chat. we will kindly request you by the end of the session that you click it, and then so you can share the feedback with us. There are a few things that I can say, looking at the nature of the patient, there are a lot of things based on what Nottingale or RFM has shared, that the patient is closed up, not willing to share more about the treatment. There's a lot that needs to be done. Maybe the patient was not well comfortable, the rapport was not yet good for the patient. There might be a possibility that the patient was attending Babane and maybe defaulted the chemo and then has changed the care to RFM now, because if you can see that this problem might be a year old, but the chemo that was taken for the same problem, you'll discover that the patient maybe defaulted the treatment and then opted to then run away from Babane to try luck at RFM. So I think the issue of the follow-up with Babane to find out the patient, you will discover that the patient is defaulted. And once the issue of default has been found, there are issues that we need then as a facility to dig in, other than referring to another one without knowing what's the history behind, which may include the issue of the reason for the patient to default. You will discover that maybe beliefs or cultural issues have taken place. Most of the time, when men in the country of Kaposis are called, they first take the traditional route. So they will try when they come, then they come like this man at the advanced stage, where we find that even the chemo won't be that much beneficial for the patient. So I would advise that the history must be digged in and be found. And the file of the patient, I think, can be found in Babane, and the Babane chemo unit can remember the patient so that we can know if we then are referring the patient to TB hospital, we understand the patient better. Another thing that I will then say we need to look around is the issue of the diagnosis itself. That the patient must be aware of the diagnosis, must be aware of the prognosis too. Because sometimes the patient will cooperate. We have heard that the patient is on art. We don't know if the patient is adhering even to the art treatment itself. So I think the issue of diagnosis explanation in the cultural educational level of the patient, so that he can understand very well. You will find that even this patient is playing the blame game, that who he is blaming. Sometimes they will believe it's a cultural issue. So you see, then they will not cooperate. Even if you say they must go to chemo, you will find that the fact that the patient is not available by call, he don't want to go back for the chemo. But so if ever the goal of care was discussed with the patient, you will discover that if the patient is still willing to continue with the chemo, we know that chemo is not an easy treatment. So with the experience, especially a man married at 47-year-old with a mother who is sick, so also there are social issues there that needs to be addressed. How is the family support for this patient? What is the family believing? Is the patient heavy? So we need to look around all those issues. So there's a lot that needs to be done. The patient should be linked to a community service provider. It might be Hospice at home or any other community-based service provider that will sit down and unpack such issues in terms of family assessment. How are the family dynamics at home? Is the family supportive to this man? Are they not? What is the belief system of the family? What is the community the men are associated believing in? What are the belief system of this man? Because sometimes beliefs or religious, the spirituality of the patient plays a major role in terms of decision and care. So we need to know at this stage. At this stage, we know that sometimes, even if we are trying palliative care chemo, death can be imminent at any time. We see that the patient is already complaining of chest pains. We don't know what is happening internally than the outside that we are seeing. So I will propose that also should be considered. So the family involvement in HIV era, in AIDS era, we were talking about the issue of family involvement, the care support, you know. At this time, when you have such a case of this patient oozing, smelling yellow fluid, a man, you know, a Swazi man, you know, smelling, you can tell that even the dignity of this man might be compromised. If you can sit down and analyze those dynamics, you will find that there is more that is affecting this woman other than we can then refer to something else. Another thing that I need to also involve is that the ethical issues. If we talk of referring the patient to chemo, is the chemo feasible, or is it going to benefit the patient? What impact is going to have on the patient? If it's going to benefit, then is the patient going to afford? So we need to also go down into the issues of finances, you know? The social part of the patient must be assessed very well. So I will recommend that you do that. If now the patient is not picking the phone, it means that there is a gap. The patient can be or should be linked to a community so that when you are following up telephonically, you are not reaching the patient. Then you can connect to that community unit that the patient was referred to find out if the patient is still alive. We don't know. So to find out if that's the case. And then another thing is that I've also touched the issue of the goals of care. Goals of care must be discussed with the family, with the patient, at the context of their need. So I don't know if the patient was informed very well and what was his voice or comment when he was referred to another facility, or what was the communication. So I think another thing we need to strengthen in our palliative care setting is the issue of communication between the team itself and then between the stakeholders or partners that we have in the care of the patient and the patient itself, and including the family. We need to look around those issues. And then we can now talk about the issues of adherence. Then we will know if the patient adherent. You will find that there are nutritional problems. I've discovered that this man is self-employed. Now that you are self-employed with a smelly discharge, it is impossible to have a market by then. So there's a lot that we need to anticipate that needs us to sit down. You will find that this man is not opening up his anger issues. You see, he needs some treatment, spiritually, emotionally. So we need to welcome him. Maybe he is used to some healthcare workers rejecting him. Some people are holding their doors, not willing to open up for him. So he's closing up to anybody. But I think there's more that needs to be done, and we need to heal this soul, psychological pain, spiritual pain, emotional pain, and the physical pain, except thinking about maybe curing the incurable possible. That's what I can suggest for the facility, that they need to consider such issues in looking around the patient who's presenting in such a case, especially a patient who's not willing to. You'll discover that one of the symptoms there is depression and anxiety. So we need to find out what is the patient anxious of, what are the patient anxieties. This is a man, you know, in the country, in Swaziland, you rarely you will see men presenting with anxiousness. But if that's the case that we found, we need to dig in. What is this man anxious of? Because anxiety combined with depression in it, this man might commit suicide at any time, you see? So we need to dig more in the psychological area to find out what could be troubling. There's a marriage that is under compromise already here, and there's only one sister. What is the relationship between this man and his sister? And what is the role of this man playing in their house? We are used to that in this country. Mostly the men who are living with siblings and the mother, you'll find that they become the breadwinners. So we need to look around those issues. So before then we can think of referring to chemo, there's a lot. So it's a goal discussion. The therapist must be evaluated, the ethical issues, the family, the social issues needs to be addressed and assessed with immediate effect. I don't know how you can do it. If you can stand up quicker, deal with the spirituality of the patient and the socially than the otherwise. That would be my suggestions for today's case. With that in mind, I don't know if anyone wants to add something. I have 5 minutes to close. Let me request you, colleagues, to kindly register your names on chat. Kindly register your name and your information on chat. We can appreciate to have that. Otherwise, thank you so much. In the absence of any question, if anyone wants to add something or any question, I can appreciate that. I can see Pennsylvania wrote there, family dynamics, belief system, and social issues needs to be addressed and be assessed. So in the absence of any question, in our next session, we will look at, we will continue with our goals of care. We are going to continue with the series of communication in palliative care. We have addressed the issues of the elements of communication, family meeting, how to hold the meeting. We have also looked at how to break the bad news. We have also looked at how to initiate advanced care planning discussions. So now we'll be looking at how then do you move with a patient in terms of ongoing discussion? How do you make those follow-ups with communication skills? So we'll be looking at that one on the 27th. So we'll be looking at how do we move around and say, discussing the ongoing goals of care with the patient. How do we move with that with the family? So we'll appreciate that if you can invite more people to join us so that we can provide the care. Today we've learned that the ECHO platform is to support us as healthcare workers so that we can have time to share information together in ensuring that our patients, regardless of the socio-economic status they have access to the best care. To our healthcare workers, regardless of where you are placed, you are capacitated and having more capacity to handle even palliative care related issues at your area without moving to a certain place to require that knowledge. Thank you so much for attending today's sessions. Kindly remember to click the link there for feedback. We will appreciate that. Thank you.
Thank you, Mr. Sanjay. Bye-bye.
All right, let's see one another, the 27.
Bye-bye, thank you.